Great. So I'll turn it over to Kellie and the team over at Wentworth-Douglass.
All right, thanks, Vicki. We're really excited about all the interest in this project. My name is Kellie Mueller. I am Assistant Vice President for Behavioral Health at Wentworth-Douglass Hospital. And I have two co-presenters. Christine, you want to introduce yourself?
Sure. My name is Christine Morris. I'm one of the psychiatric nurse practitioners at Wentworth-Douglass Hospital, part of the behavioral health team there, working primarily in our outpatient practice, but also providing consultation services to the inpatient setting over at the hospital.
Hi, my name is Jen Stout. I am clinical supervisor over here at the doorway at Wentworth-Douglass Hospital. We do a lot of assessment and referral services here at the doorway for folks with substance use disorders. And then I also do some clinical work with folks with co-occurring trauma and substance use disorders and some clinical supervision with folks as well.
Thank you. So we're going to spend some time this morning talking to you about our project, our SURT project, which is our substance use resource team. For many years at our organization, which is probably similar to a lot of the organizations you work at, there's been conversation around how do we better care for patients with a substance use disorder. And a lot of times the word addiction specialist will get thrown around. And I've been asked a number of times in my role, well, can't we just hire an addiction specialist? And sure, we could. They're a little bit like unicorns, right? There aren't a lot of addiction specialists out there. It's typically a psychiatrist with a subspecialty, and everybody is interested in that type of resource right now. So there's not really a lot of that resource out there. And over time, we realized, even if we could hire a person to be a substance or to be an addiction specialist, it's still one person. So it's one person trying to support, a large organization like ours with, about 3,000 employees. And that just didn't really seem to be a good model. So we've had talks with different departments over the years about what would be a better idea. And about a year and a half ago, we were having a lot of conversations with our Women and Children's Unit, which is our birth center. And they were seeing an increase in the number of moms who are coming in to deliver who had a substance use disorder, and their staff really felt like they weren't doing as good a job as they could be. And so we had been having conversations about how do we educate, how do we support, and around that time last year, the Foundation for Healthy Communities reached out to us and talked to us about a grant that they had available to improve the care of patients with a substance use disorder in the emergency department. And we got very excited, obviously, about the grant money. And we kind of countered by saying, we'd really like to work with you on this project, but we really want to look at it from a systems perspective and not just the emergency department, because that's really just a point in time in the care people receive with us. And so the foundation was very excited about that possibility. And so we started a project with the Foundation for Healthy Communities. As we started to think about, well, what exactly is the need? We thought about some of these conversations we were having with the Women and the Children's Center and some other departments. And really what it boiled down to were these themes, that we had staff that felt like they weren't competent. They weren't sure they had the right skill set to be able to provide the best care to our patients. And of course, that's always our goal, is to provide evidence-based, compassionate, safe care to our patients. And then it wasn't just about competence, but confidence and comfort. We were also hearing from the staff that they didn't necessarily feel comfortable. And some of that was the skill set, but some of it we also realized was because they may not have enough education about the etiology of substance use. And that may lead to some stigma and judgment, and that was probably playing in part of their lack of comfort as well. So we knew we had to think of a way to provide support, both from a technical perspective and an emotional perspective. So from a technical perspective, do I have the skill set? Do I have the education? Do I have access to things like withdrawal protocols? But also the emotional. We know that working with these patients can sometimes be complex. They can sometimes bring up some emotions and feelings in ourselves based on our own personal experience. And so there was a lot of emotional exhaustion, so compassion fatigue, that was playing into some of the barrier for the staff in being able to provide the best care. And then there was also some frustration around not really understanding what kind of resources were available out there. So not only resources for the patients, but when you talk about that technical and emotional support, what kind of resources were available to the staff themselves. So we pulled together a project team, and the way we address projects here at Wentworth-Douglass is through a process we call operations excellence, and it's a very structured approach to developing a project. And so our objective really was, instead of bringing in an addiction specialist, right, that one person, how do we create a whole team of resources? And so that's what led to the SURT acronym, the Substance Use Resource Team. And our original objective was, what if we trained 6 people to be this resource team? And that team could really provide the support to the organization in a way that one person alone couldn't. And so we pulled together our project team, and we started out with those people that we knew had the most passion about this topic to really help us develop this team. And pretty quickly realized that we already had those 6 people. We had those 6 people on our resource team. And so it caused us to step back and think about this a little bit differently and realize, instead of having this one 6-person team, maybe we'd approach this through a more tiered approach, because we had these 6 people who were already interested and who already had a higher level of expertise. So for example, we had Jen, who you just met, who's worked in the field of substance use for a long time. And we knew that she could provide she didn't need the education. She was actually going to be someone providing the education. And then Peter Fifield, who's our behavioral health manager for substance use. We had a pharmacist on our team, on our planning team, who has a passion and had really helped create a lot of the detox protocols from the hospital. We had a hospitalist who had worked in an MAT clinic in the past and was really passionate about providing increased education and better care to our patients. And then we had Christine, as she mentioned, who works at Great Bay Mental Health, and another NP who were helping provide some bridge appointments to patients for MAT. So we already had a handful of people that we could consider to be our experts. So what we did was we divided this concept into 2 levels. And those handful of people, those 6 people, were going to be designated as mentors. They were really the ones who already had a high level of expertise, and they were going to be able to provide support and guidance to the rest of the people we were going to train, which we were calling champions. And so our original objective was to train, we thought, I don't know, maybe a dozen people. Maybe if we could train a dozen interdisciplinary staff, they could join the 6 mentors, and together we'd have a team of, maybe around 2 dozen if we were being really lofty with our goal originally. We'd have about two dozen people who would have a higher level of expertise and passion, and that's what would become our substance use resource team. So that was our original goal. So the next step was to think about how we were going to do that. How were we going to create these champions? And we knew that was going to be through education. We needed to find a way to improve and increase their comfort and confidence, because that's what we were hearing from staff, when we'd been having these individual meetings prior to this project. And so we knew that we could increase comfort and confidence through education, but we needed to get a better sense of what education they needed. We knew what we thought they needed, but we didn't know what they thought they needed. And so we thought it would be helpful not only to try to get at some of those educational needs, but also as a way for us to measure this ultimate success of this project was by putting out a survey. So before we got too far down the road with developing our training program, our initial focus was on the hospital and the nursing staff and providers at the hospital. So we put out a survey back in November, and we're going to talk a little bit about those survey results later. But we put out a survey where we asked the staff questions about their confidence and their competence in caring for patients with a substance use disorder, asked them about their knowledge of resources. And in that initial survey, we also asked them about their educational needs. What were the topics they thought were important? And we had identified some topics ourselves. And so we threw those out there as suggestions and had them rate those. But this was our attempt at really figuring out, where were we going to start? How were we going to put together a training program? So I'm going to turn it over to Jen now, who can talk more specifically about the training modules that we put together.
Okay, hi. So when we were thinking about developing these training modules, and we were able to do the the piece with sending out the survey within our staff, another piece, of course, to look at is, who are the patients who we're treating, right? And what are they feeling like they need? And anecdotally, again, just like with staff, we were able to kind of, throw out a lot of thoughts and hypotheses, and I kind of went to the research to see if it, really bore out what we were seeing, and it really does. So we knew staff are struggling, and we knew patients were struggling when they were inpatient for some medical issue and had a co-occurring substance use disorder. And what we were often seeing were patients hospitalized with infections, blood infections, cellulitis, endocarditis, liver disease, things like that, that were related to their substance use disorder. And I did a little research, collected kind of the data that's already been done. Not a ton of data on this, but we do know that folks who are diagnosed with substance use disorders are up to 3 times as likely to discharge the hospital against medical advice than those without a diagnosis of substance use disorder. And then when a person does leave AMA, the risk of mortality in 30 days increases, the risk of a readmission within 30 days, and the risk of being back in the ED all increase. So it really, I think understanding why a person is leaving AMA and the challenges from the patient's perspective is essential, because maybe we're missing some opportunities to work with folks to have a more useful hospital stay that could potentially benefit, right, both the patient and the folks working with them. So in the research kind of bears out, a couple of themes. First off, we have the lady wagging her finger in the middle. Those who were inpatient felt that in interactions with hospital staff, they perceived that they were treated differently and maybe judged. This is a study, I kind of am combining 2 studies. One was recently done in 2017 in Mass General, and really does, pull together what we see at the doorway and what nurses and providers are all talking about, the frustrations of the clients who we're working with, the patients we're working with. They feel stereotyped. Maybe they feel reprimanded. Some folks have said in the hospital, a nurse said to me something like, well, if you didn't do this, you wouldn't be here. So kind of that, little stinging comment that feels hurtful, that feels judgmental. Maybe feeling that their pain isn't taken seriously. Feeling that staff did not understand substance use disorder, felt that they weren't trusted by staff, right? So when they're in the bathroom, the nurse comes knocking. And feeling like they were, always treated maybe with some suspicion of what an ulterior motive would be. Now, I think this could be an interesting, source of discussion in when we talk about questions, because a lot of these, we do have to be careful. We do worry about folks, right? So here we're just looking at the patient perspective, but I want us all to remember there's both sides. Patients spoke a lot about feeling like their pain wasn't taken seriously and wasn't adequately controlled. Patients felt that they had their withdrawal wasn't taken seriously or appropriately controlled. A lot of folks said, they used right before going into the hospital because they were so scared that they were going to detox while they were in the hospital. And if they got to the point where they were detoxing and it wasn't being taken, they felt it wasn't being treated appropriately. And of course, we all know that feeling of detox is pure hell. That would be really, a reason for them to leave against medical advice. Finally, feeling the hospital restriction, like I can't do what other people can do, maybe. I can't have visitors that other people can have. So how we think of visitor policies, sometimes felt judgmental or unfair, came up a lot in the literature to some of the folks with substance use disorders. And then, that feeling of not being able to leave their room, not being able to go outside, not being able to have a cigarette comes up a lot for folks that I've worked with and also in the literature. Feeling powerless, no control. And a lot of folks say it feels like jail. So it can be a real kind of triggering environment when you're in a space that to you feels a lot like jail. Now, this doesn't mean everything we're doing right is wrong, but I think it is really important to kind of turn it and look at the patient perspective before we, we're talking more about how we're going to proceed with the modules. So we kind of divided our modules into core modules and then kind of the broader set. And when, of course, now we've hit the COVID portion of our timeline. So what I think we initially thought of having a bunch of, really in-person interactive educational opportunities turned into something totally different. And I think in the end, it actually probably maybe turned out better. So what we wanted to do was we had a, really strong feeling that at least a part of this had to be interactive. We were talking about skills, we were talking about perspectives, we were maybe grappling with some difficult conversations, and that all is done best interactively and not kind of, listening passively or flipping through some screens. So we chose 3 classes to have 2 sections. One was a lecture section that was on our, HealthStream education platform. And then we had 3 classes that you would sign up for with a group and do over Zoom as an interactive group. And those were Substance Use Disorder 101. So the first one just kind of gave the real basics of addiction, neurobiology of addiction, the cycle of addiction, things like that, to give just a real baseline. And then Substance Use Disorder 102 really talked more about, the experiences and what are some behaviors we might see with folks on the floors who are struggling with feelings of cravings or withdrawal, or feelings of being judged, right, and stigmatized, and maybe some ideas of how to approach that aspect of the work. Trauma-informed care 101. Again, the first one was just basically what are the tenets of trauma-informed care and what does that look like in a healthcare setting? And then the second one, we talked a lot about compassionate boundaries and self-care. So we're working here with really complicated, mostly traumatized individuals who are suffering and struggling, and they're in the hospital, so it's not their best day. So how do we come from a place where we are setting boundaries that are appropriate and within the scope of our roles and our practice, and also compassionate, and really finding ways to take something that is difficult and see it from another lens that can help us build and shore up our own feelings of compassion. And then the most important part is, how do we do that in a way that's always attending to our internal sense of well-being, so that we can avoid, compassion fatigue and burnout as much as possible, or at least notice it and treat it within ourselves as soon as possible, so that it doesn't become the way that we're practicing and kind of stuck within us. And then finally, motivational interviewing 101, and just those real basic skills about how to talk about ambivalence, how to move people along in terms of stages of change, how to not expect an outcome that is not within a person's, stage of change. So really, and the live class is a lot about hashing out those ideas of, when I'm working with someone inpatient who does not want to go to rehab after their inpatient hospital stay, right? And who has no interest in making that drastic change right now because they're in this pre-contemplation stage. How do I kind of accept that and also have some skills to use at that stage of change that the person is in that could maybe move them along a little bit? So those were our core modules to kind of create the lens of what we're doing. And then we buffered that with lectures that were, again, on our HealthStream, that people could access kind of in their own time frame. And that included a module on harm reduction. Talked about SOS came and did a lecture on peer recovery. Alcohol use disorder, opioid use disorder, stimulant use disorder. Those were more of our kind of medical lectures that really gave, a person an understanding of the ins and outs of how all of these disorders are working, how the substance works in the body and in the brain. And then the patient experience module, which ended up to be a really powerful module of some folks who had been hospitalized and were able to kind of come back and talk about their experience of being someone with a substance use disorder inpatient in a hospital. And that turned out to be a really powerful module as well. So that was what, these are the 1, 2, 3, 4, 5, 6, 7, 8, 9, 12 classes that folks were asked to complete in a certain timeline in order to become a SURT champion.
Thank you, Jen. It's also worth noting that to take these 12 modules would take people somewhere around 14 hours to complete. So it really was quite a commitment for those people that wanted to do this. So now that we figured out what we wanted to teach people, we needed to figure out who are we going to teach. And so Christine's going to talk us through how we assembled our team.
So really initially in terms of, so we have our mentors, we have our educational component. So who are we going to teach that to? How are we going to identify those people? So we sort of looked at departments within the hospital. Initially, this was a hospital-based focus only. What was the biggest need for substance use disorder treatment? Where were we seeing the most substance use disordered patients? Who were already our allies in the hospital, who were already having that contact with our patients with substance use disorder that could sort of help, move this program along. So we, really right out of the gate, the emergency department, behavioral health, social work, the care coordinators, hospitalists on the inpatient units, those were really the places where hospital staff was having the most probably amount of contact with the substance use disorder population, sometimes presenting for specifically substance use disorder related problems, other times coming in for a medical problem, and then you sort of have the substance use piece of it as an incidental finding. So once we identified the departments, then it was, so how do we identify the people within those departments that might want to be a part of this substance use resource team? And so an invitation went out to managers in the form of a letter of the various departments in an effort to help identify their staff members who may be interested in becoming a champion, who may be interested in, taking these modules and being available as a resource to other staff members, their coworkers within the hospital, for those times when a little bit of extra help was needed, a little bit of extra support. So as we mentioned, the initial focus was within the hospital, and from the work that we did there, we identified 60 people that came forward and wanted to be a part of. I think we would have been happy with a handful, so 60 was a really pleasant surprise for us. That was an amazing achievement for us. So once we sort of established the hospital piece, we recognized and identified those 60 members. We figured, why, let's open it up to the outpatient as well. Primary care practices, the specialty care practices. I think initially in that first go around, it was primarily primary care practices and some of the OBGYN practices that maybe also had some, contact either in the offices or on the women and children's floor. That led to another 40 people. So our first go around, we had 100 people interested in becoming a champion for this project and being a resource to the organization. Huge accomplishment, I think. It was an all or welcome approach with clinical staff, so MAs, nurses, providers, non-clinical staff, your front desk people, anybody behind the scenes, maybe there was someone on, facilities management or materials management that maybe they don't have direct patient care, but they can be a champion to the organization and a champion to their coworkers, an ambassador to the organization on this project. So we really kind of reached out to everybody. We wanted this to be a far-reaching, and anybody who was interested was welcome to be a part of the project.
Thanks, Christine. And this next slide really depicts that. It's a little bit busy, so we don't expect you to read the whole thing. But as Christine said, we were hoping for a dozen. We got 100 people who are interested. We had a handful not completed because they either left the facility or something personal came up. But still, we had well over 80 people. I think by the time we counted I think we had about 90 people complete the training the first go round. And really, this slide just shows you how vast the reach was. We had members from 30 different departments throughout the organization participate, and from 25 different job categories. So as Christine said, clinical, non-clinical, inpatient, outpatient. One of the interesting things was word of mouth. We'd have people reach out to us that had heard it from a friend of a friend and who were interested. So that was really exciting when we heard that there was some excitement among those people who had started the classes. So this really was far reaching, which was pretty exciting for us. And so once we had all of these folks trained, the next question became, well, how do we sustain the momentum? How do we keep this project going?
So as we mentioned, identified the project, identified the mentors. Now we have the champions. And so what do we do with that? Well, we broke the champions up into what we call cohorts. I think right now we have 4 of them. At some point, we may need to expand and kind of break them up a little bit. I think we've tried to group them together as best as possible based on maybe similarities within the units or similarities within the outpatient. Some of the cohorts are a combination of both inpatient and outpatient staff. The cohorts are each led by 2 mentors, and we tried to pair it up so that there was a clinical person, so Jen or Pete, and then some sort of a medical background. So whether it was the hospitalist or one of the nurse practitioners or the pharmacist, so that there was the clinical and the medical piece of it, kind of leading the groups. So the cohorts, up until the end of last year, we were having monthly meetings. COVID has sort of thrown a little bit of a monkey wrench in things. The acuity just got really, really high. People were having a hard time carving out that hour, once a month to be able to meet. And so we sort of put those on hold with the idea that we would relook at that at the beginning of 2022. So I think next month we're going to look to reinstate those meetings again. The expectations for attendance and participation, I would say we had some expectations, that people would try to attend at least 6 of the 12 meetings, that people would participate. Things were kept confidential. Part of participation was, having your camera on so that people could be seen. I think in terms of our expectations for the actual attendance, as things got busier and busier with COVID, I think we did sort of, I think we had to relax that a little bit, the expectation that people would be able to consistently attend, even including some of the mentors, depending on what was going on for us. It just became very unrealistic with some of the other things that were requiring our attention. So I think some of the positive of the cohort meetings, in addition to being, sometimes it's just an educational, maybe people come in with some information that they've learned, they share it with the group. We use it as an opportunity to go back and look at cases that we have had some part of, and it's not meant to be a Monday morning quarterback. It's not meant to be any sort of, blame and shame. Just sort of opportunities to go back and relook at situations. And, if this situation comes up again, is there something that we could do differently to address that substance use concern? Is there something we could do different to address the pain management, the withdrawal management? It's also a great way for staff to receive emotional support. There were at least a couple of meetings that Jen and I had with one of the cohorts where there was, a couple of patients that really kind of touched many different people, both inpatient and outpatient. And it was very difficult situations, and it left a lot of feelings for people. And so the cohort groups were a really great way, our meetings, to be able to process and give people a safe place to explore their thoughts and feelings and the emotions that those patient experiences elicited for them. And then how to move on and be okay with, knowing that we can't control everything, and we can only, as we love to say, we're responsible for the interaction, but not the outcome. And how do we be okay with that? Communication, very, very important. There's regular emails that go out reminding us about trainings, information about upcoming trainings. If someone knows of something that's coming up that they think people might be interested in, they'll send out an email, just kind of giving people the heads up if they would like to join. We're constantly asking people to help spread the word. Really, that's part of the, one of the things that we hope the champions will do is that they'll be ambassadors, go back to their units, talk it up. We think that, showing our appreciation for the amount of work and effort that people put into this, and having a certificate that kind of identifies them as a champion for the SURT team, I think that really helped. It gave people that sense of appreciation for their accomplishments and their commitment to the project. ongoing education. We're always, keeping our eyes out for new modules that we can offer on HealthStream, other training opportunities that are coming up. I know I personally really enjoy, Mass Gen does some great substance use disorder conferences. They usually are around at this time of year. So opportunities where people can get some additional training. Someone has Gen referenced research articles. So if someone comes across an article that they think might be helpful, sending it out to the cohort groups, making sure people have access to kind of up-to-date information and research. Organizational awareness, making sure that people don't forget that we're there, that just because maybe we're not being utilized all the time doesn't mean that we don't exist. So reminding people in emails, we have a newsletter for the hospital called Leading the Way. And so making sure that information is in Leading the Way when we first started the program and identifying the mentors and introducing the program. We have a shared drive within the hospital where people can find a list of the champions and the mentors, but we're kind of trying to look for ways where we can make that more public, maybe a little bit easier for people to put their hands on in the moment, to get a hold of somebody. Always encouraging, again, our champions and our mentors to go to staff meetings, talk about SURT, make sure that people know that the resource is there to utilize. We want to help. So just making sure that people know that.
And so at this point, we had, developed our project, developed our trainings, identified our team, trained our team, provided the cohort follow-ups to support our team, but did all of this make a difference? Was this a successful project? And we felt successful, as Christine said, aiming for 12 people and getting, almost 100. That was quite the accomplishment. But what did those folks think about how this was impacting their work? So as I mentioned, we had put out a survey back in November to get some baseline information. And so we measured the percent of people who agreed or somewhat or strongly agreed that they felt confident. Then we measured, did they feel comfortable? And then we asked about, did staff feel like they understood what supports were available to them? And did they understand what supports and resources were available to their patients? And as you can see in our baseline data, the percentages of somewhat strongly agree were fairly low. Our highest score was only 60% of our staff felt confident in their care of patients with a substance use disorder. So December is when we kicked off our project, December of 20, developed our training, identified our team, rolled out the training, and then June 1st, we considered to be our go live when those 90 plus champions had been identified and when we communicated that to the organization. So we've done, we did a post-intervention survey in July, another one 3 months later in October. We're just literally this week wrapping up the third and final post-intervention survey. And we were thrilled, as you can see, in the survey results of July to show that there was a significant improvement in people's confidence and comfort in working with patients with substance use disorder. There was also an improvement, although not quite as great, in terms of resources. So we understood we had some work to do still with making sure people understood what was available to them and to their patients. Did the second post-intervention survey in October, and again, really maintained those high scores. We were happy about that. We were afraid that maybe, a few months later, people would forget about us, but they didn't. We saw just a slight dip in a couple of the scores. And then I'm going to talk a little bit in a minute about how we rolled out a second series of training this fall. And so, hot off the press, the third round of surveys this week, as I said, aren't complete, but the numbers I looked at yesterday, we have about 60 respondents as of yesterday. The numbers of the percentage of who feel confident and comfortable are even higher than the numbers you see here for October and July. So they're about 86, 87% now are saying that they feel comfortable. And these numbers were just for the hospital, because if you remember right at the beginning of the presentation, we talked about how we were just initially focusing on hospital staff. So we put the survey out to hospital staff, wanted to keep the data clean. So that's the same group of staff we've been continuing to survey throughout this process. We have intuitively felt like this project was very successful and has made a difference in terms of the culture at the hospital. And then I think this data just helped really support that. So what comes next? As I said, we initially thought, in a perfect world, we could offer this training series twice a year. It really is a lot of work. The project obviously was a lot of work up front, but even rolling out the trainings, the communication, the coordination, the tracking of everybody's modules. Jen and Pete put in a great deal of time because they're the two people that do those 3 live follow-up modules. So we want to offer, a number of those for each one, so to make sure we can get everybody through them. So we felt fairly confident we could do that twice a year. We offered another session that started this fall. Again, we targeted a few departments we thought could use the training. So we reached out to our physical rehab department, pain clinic, surgical services, security, cancer center. We again offered it to all the previous departments who had participated before. And again, probably didn't set our target quite high enough because I thought, well, the second go round, we won't get quite as many people who are interested. So we thought maybe we'll get, another 40 or 50 people, maybe half we did from the first time, or half as many. And to our surprise, again, we had 80 people sign up to participate in this fall training series. And even as our acuity and volume started going up in the hospital with COVID this fall, 54 people met the original deadline of completing all their trainings by the end of November. And what we decided to do was pause this second series to get us through our surge here through the winter. And we offered an extension for people to complete. Those last almost 30 people had till the end of next month to complete their training. And then we'll do some more live classes to try to get them caught up. So we're pretty confident that by, at some point in March, we'll have almost all of those 80 also complete their training. So that'll put us up to, we're close to 200 people in our first year of training, which is mind-boggling to us. We also developed a flyer, again, trying to keep that top of mind awareness that we distributed to different departments to hang up and remind their staff about accessing the SURT champions. We have a central list of all the SURT champions so people know who they are. We've asked the champions to make sure their teams and their departments know who they are. We've talked about the idea of rounding. Could the mentors do some kind of rounding in the hospital in particular? Again, that was one of the things COVID stopped. We hadn't really fleshed out what exactly was the goal of that, but now that we have this large team, we might be able to implement rounding. And we also wanted this not to be the end, right, of our work. Developing the SURT team and really trying to get at changing the culture at our organization really needs to be the start of our work. So using the SURT concept, that's really the foundation upon which we're going to build all of the rest of our efforts. And so over the next year, we really hope to do a comprehensive evaluation of our entire system and how the care of patients with a substance use disorder is how it gets sort of handled along the continuum of care, and how can we improve communication and workflows. And then last but not least, again, this is one of those, I think, COVID delayed projects. We were hoping by mid 2020. I think now we're going to be happy if at some point in 2022, we can, I meant 2022, that we can complete a toolkit. So part of what we're telling all of you is we're sort of sharing our blueprint, right? This is the process we went through. These are all the elements you need. I'm going to talk about lessons learned in a second. What we want to be able to do is get that all down in writing and create sort of a blueprint or a guide, including some of the modules, our recorded modules for training, and be able to really distribute that widely throughout the state. We work with the Foundation for Healthy Communities. We work with the community practice, both for substance use and behavioral health, and really be able to make this toolkit available to anybody who wants to use it. Samples of our welcome letter and our invitation letter and our description of who makes a good champion and what are the expectations of them. So we're excited about putting that together as soon as we can take a deep breath for a few minutes and sit down. We're hopeful to get that out this year. And so if people are thinking about going down this path of doing something similar in terms of developing a SURT team at their organization, we thought it was important to share our lessons learned and what we would have done differently or what we think we did correctly. Creating a comprehensive plan, I think, was really the first place to start. So really being very focused on our project around what was our goal statement, how do we stick to that, how do we really come up with very fine details and accountability for who was going to do what as we put these plans together. And as Christine had mentioned early on, our project team, really we recruited all our friends, right? We recruited people we knew were already strong advocates for this and had a passion. And so those folks really helped this project come together nicely. and being flexible. As we talked about, our original plan was to create a 6-person team. We then, shifted to a tiered approach. And the second go round, we actually recognized, Jen mentioned those 3 really heavily medical modules that were about detox protocols. They were like this over my head. So the second time this fall, we said to our non-clinical participants, well, we'd love for you to watch all of the modules. If there's not going to be time or interest in doing all of the modules, then they could sort of not, we excluded them from having to watch those 3, especially if they weren't caring for patients at the bedside. And then module review, removing and adding. Jen had pointed out the patient experience module, and there's a bit of a lesson learned story in that. That was not in our training originally. We had another module about coexisting disorders, and that module just kind of missed the mark a little bit. And so we thought, okay, we might not use that again. But as I was talking about this project at a meeting one day, Tanya Lord, for any of you who know who she is such a strong and passionate advocate for patient experience, said, well, I'm assuming you have a patient advocate model or a patient perspective module. And it was one of those, like palm to the forehead moments. We're like, no, probably that would be the most important module we should have. And it was the one we missed. So a little bit egg on our face, but we were then fortunate to be able to work with Foundation for Healthy Communities and Tanya, and she helped put together that module for us. And now we're really excited. That's probably one of our most popular modules for people and most impactful. So I think if we had asked a larger or wider audience about what we should include, maybe we would have fleshed that out ahead of time. So not just looking at what we thought was important or what our own staff thought was important, but had we reached out to Tanya, had we reached out to SOS Recovery, had we reached out to some of our partners in the community, they might have been able to notice, that was missing. And then we talked about the champion expectations, so if somebody took the training and never participated in another thing again, that's okay, right? We have one more educated person out there about substance use disorder. That's not a bad thing, but we did want to make sure we had enough people on the team who really expected to have a role to play as a champion. And so really being an ambassador, Christine mentioned, going back to your department, talk this up, make sure your team members know who you are, participate in ongoing training, and really being able to do something. If you work in the medical field, you've heard this concept of stop the line. If you work in an operating room, everybody is empowered to stop the line and say, whoa, I think we're operating on the wrong foot, or I think we, just pulled the wrong medication, or I think we didn't, do true patient identifiers. And it's an idea of empowering people to stop and say, let's take a time out for a minute. We want champions to be able to do that at the bedside, in the physician's offices, saying, well, let's step back for a minute. Maybe there's a different approach we could take with this patient. Have we really looked at the detox protocol? So we want the champions to be active in their role. And then the other thing, which you've heard mentioned too, is broadening your view. So again, we really invited some very specific departments, but as word started getting out, I'd get all these emails. Oh, I'm just the person who works at the front desk. Could I take this training? We were able to respond back and say, first of all, everybody can take this training. And secondly, you're the first person a patient encounters when they walk into a practice. You're vitally important, on our team. So it was that understanding of everybody has a role to play on a SURT team. And to think about places you might not normally look for members. Word of mouth got to our integrative therapies team, and there are several people on that team who do acupuncture, and they happen to had taken some classes in providing acupuncture to patients with a substance use disorder. So they caught wind of this and said, could we participate? Now, I never in a million years would have thought of inviting them. So that was really exciting for us. And I had somebody who wanted to participate, as Christine mentioned, who didn't even interact with patients at all. But I knew that she had personal experience, and I knew that she was taking this class because it meant something to her personally. And, we recognized at that point that we had a real opportunity. We had really just been thinking about improving the care of our patients, but then we started working on the concept of becoming a recovery-friendly workplace, because all of these SURT members also now are champions and supports and advocates for their coworkers. So if we can change the culture of making it okay to talk about this in respect to our patients, that also changes the culture for, I might have a coworker reach out to me who has a personal experience with substance use, who now feels like they can get the support they need need, or maybe finally kind of acknowledge what they've been struggling with, because they know I'm a champion, and they're likely to be met with some compassion and understanding. So this training has really allowed us to also embrace the idea that this is something that is good for our employees, which in turn then become good for our community. We all did our own personal reflections on this whole project, and some of the things that we talked about were, raising the bar. Our goal was to train 12 people, and we trained, we're now up to, almost 180. So I think if you raise the bar, people will rise to it. So I think we would really advocate for people to have lofty goals in a project like this. Staff were really hungry for this. We stood back and scratched our head about, why did so many people raise their hand to do this in the middle of a pandemic? 14 hours is a lot of training. And we think, first of all, people were hungry to do something not related to COVID. We think, secondly, the need for this increased during COVID, because we all know that the incidence of substance use has increased. I think that more and more people have their own personal stories and their own personal experience. And so that there was that piece as well. And then we also recognize that champions come at all levels of readiness, right? We didn't do any kind of entrance exam or interview to allow somebody to be a champion. As Christine said, all are welcome. But I think that what they found in the cohort meetings is that, people have been honest about, being skeptical maybe about some of the education, and saying that they're not really sure they agree with some of it. And that's okay, because admitting that allows there to be really rich conversation in the cohorts, and to embrace that and understand that that's the case for our teams. So that is as fast as we could talk through a really long project. But we're happy now to, Vicky, I don't think I could see chat. I'm going to take my share down. So I don't know if questions came in, but we would welcome any questions.
I haven't seen anything in the chat yet, but I just want to thank the three of you for an excellent presentation. It's always nice seeing what the hospital is doing, and just continues to make me proud that Wentworth-Douglass is my local hospital and where I go for care. Always impressed with the work that you guys do. So I think people can either put questions in the chat, or if they want to unmute themselves and share thoughts or questions, we have a little bit of time for that.
One of the issues that I run into fairly regularly with patients is that a lack of continuity between the teams when the teams rotate. So several times throughout the talk, you talked about kind of this issue in regards to pain management. And if you're coming into the hospital and you do have, or even have a suspected history of substance misuse, then the red flags start going, and a lot of times I'll see a patient will have these issues and they will be struggling, and they're bringing a lot of trauma with them anyway. They get things sorted out, and then, well, they think they do, and then the teams rotate, and it's like it starts all over again. That frustration comes up, and then AMA out the door. So I was just kind of wondering if there was a way that you had, if you'd noticed the same problem about kind of this continuity of the mindset with the teams when they're working with them, and how to maintain that, because there's a lot of frustration. I'm LICSW with a behavioral intervention team for inpatient, and I get called in a lot for support. And really, a lot of times at the end of the day, it's really legitimate frustration with, perceived communication issues and feelings of being untrusted and not knowing really what the plan is or what they can expect. Does this sound familiar to anybody? Or
yeah, well, and I think Jen and Christine can both talk to this, that I agree that part of I think our goal with the team too is to provide some kind of some constant, because we all know different nurses, different providers have different approaches and backgrounds. And so you're right, that care that the patient receives can really change from shift to shift and day to day. And so I think that part of the goal of the champions is to be that constant in terms of that, time out, let's step back. Yesterday we did it this way and it was working well. Yesterday we followed the detox protocol and it worked well. So I think we're hoping that the champions can act a little bit in that continuity role that isn't always there, when the staff changes. Christine and Jen, I don't know if you have any thoughts about that.
No, I think that is, I'd say that's a fair statement. I think the other thing that can be helpful, and I don't know if this is, I don't want to say that it's unique to us, but we do have a behavioral health provider in the hospital Monday through Friday. And so there's always that immediate resource there in terms of looking for that extra guidance for substance use related concerns, Suboxone help, alcohol detoxification. So I think things are getting better. I think there's always room for improvement. And I think that's, I think you bring up a good point. I think that might be an area for us to definitely kind of look at as we go forward and sort of see what kind of an impact we're making on that with this project.
I think at this point, we were thinking we have enough people where almost every shift could potentially have a SURT champion on it. And, like Kellie was saying, that could be sort of the role of the SURT champion, on that shift, is to kind of work as best we can to maintain the continuity. And also, you're right, which is as team shifts, the treatment team changes and things just change. And a piece of that is, out of our control, but we've also found that was one of the really nice things about having some pharmacists on the team and having, like people like Christine on the team, where it was actually, I know we had one case up in Women's and Children's where a provider came on and didn't feel comfortable with what someone else had recommended, was worried it was too much or this or that. And we called in a huddle and got a pharmacist on board and the neonatal provider and all came together, to have that quick huddle with SURT team members to figure out the best plan of care in a really complex situation. So I think having those SURT champions and the SURT mentors to reach out to is kind of the standard of care, especially folks from the medical perspective, has been really, really helpful in a couple of situations that I've been involved in. And also we have a way that, right, where we're turning the ship. So we have a long ways to go as well.
I could see in the chat that Karen was asking whether other hospitals in the state are using this program. Not that I'm aware of. We haven't really, as I said, we're very excited because we hope to develop this playbook that we could get out. And then if other hospitals were interested in doing something similar, they at least have some kind of guidance, about how to start. I do know that Dartmouth had reached out to us. They were starting a project, not exactly like this, but they were interested in hearing what we did just to see if it would help influence what they were going to roll out. I don't know how that happened, but I am very hopeful in the next 6 months that we will get something out so that people could implement this at their organization if they wanted to.
This is Karen. I just wanted to thank you, Kellie. Just a great presentation. Love what you're doing. I can actually see this model being adapted to some of the towns and cities that we have recently designated as recovery-friendly municipalities. So I think this is going to be a great model to replicate and adapt in many ways through our recovery-friendly workplaces. I have another quick question with regard to the against medical advice departures. Is there some type of guidance that person is given for the fact that they may be at higher risk for the next 30 days, or what is your protocol for informing them?
I can't speak to that directly, and I don't know if Jen or Kellie have more, only because those discharges are often the hospitalist, the attending that is responsible at the time. I can tell you that from a medical decision-making point, they will sometimes reach out to behavioral health to assess for medical decision-making capacity, to make sure that that person is really capable of making maybe not a great decision, but do they have the capacity to make that not great decision, and to be able to understand the ramifications of said decision should they choose to leave the hospital.
And that's a great question, Karen, now that I'm thinking about it, because initially my answer is, the medical, that's part of leaving AMA is you try to get the patient to stay long enough to sign the paperwork, acknowledging that they've been informed about all risks, be given any information that might be helpful to them as they're leaving. But this is a good, and that's true in general when patients are leaving AMA, but there's probably a good opportunity for us to go back and talk to the hospitalists here and ask them, what exactly is it that you tell someone specifically related to a substance use disorder about what their risk is if they leave? So maybe they're just talking about the infection of the endocarditis, spreading, but are they telling them anything about increased, risk of relapse or, anything specific to substance use? So I think that's a great takeaway for us to go back and talk to our hospitalist team about what specific scripting are they using when they're talking with somebody who's leaving AMA.
I think it'd be great. I'm on a little bit of a roll to determine what kind of conversations treatment facilities or detox facilities are having in terms of dialogue with folks that are leaving and, against medical advice. So, and I'm sorry, I'm not trying to hog the questions, but do you have grief support of some nature that is provided not only for staff that may lose a patient, but also, let's say, there's family member or loved ones that lose somebody, once they've either arrived at the hospital or, since they've been at the hospital. Are there resources for that I'm not aware of exactly what there is, but I think it could be important for people that, lose a loved one.
Jen, would that be the SOS has a group, and I think the Triangle Club it did one time.
Yeah, there are a couple different groups out there that we have recovery coaches in the hospital who are able to meet with folks, people and referrals to the doorway. So the Triangle Club has a group for folks who have lost someone to substance use disorder. And that's a referral that I use quite a bit. And in terms of, for staff who lose a client or a patient that they're working with, we do, Kellie and Christine probably can speak more to this, but we do, create opportunities to kind of get together to be able to process and talk about those more difficult losses as a team.
We have a pretty robust EAP program through Mass General at Wentworth-Douglass, so there are a lot of resources available to our staff.
Thank you all, ladies, and thank you all for what you do too.
Thanks for your support, Karen. That's been helpful.
Absolutely.
I would just piggyback on Karen's comment about really engaging the broader community. I know that Wentworth-Douglass has a really strong relationship with the municipalities that they serve. I love how you emphasized that, the person at the registration desk is participating in this. And I think we can look broader, the law enforcement officers, the EMTs that are bringing the individuals to the hospital and providing that transportation and stuff. How can we broaden this so that even more people are engaged in getting this training? I think it's a fabulous model that has a really lot of potential. So I'm excited to see where this goes next.
We are too.
Mm-hmm.
So I know we are just about done with time, and the next keynote session starts at 11:45. So I want to give people a couple minutes to get up and stretch, grab a cup of coffee. And when we close this out, you should land right back into the lobby and be able to join that next session. So thank you to all of the presenters and everyone for attending.
Thank you.
Thank you for coming, everyone.